Hello students, today we'll discuss an important topic, rather a examination point, very commonly kept a long case, theory, lot of things will be asked, and we see such things in day-to-day surgical practice, important for exam, CBME, Oxy, case discussion, theory, everywhere. Surgically very important is examination of thyroid, clinical approach to thyroid. So before thyroid swelling, now before going to this topic, I request all students, all viewers to subscribe my YouTube channel, share with their friends and colleagues, and press the bell. And students, please, once in 2 to 3 weeks, we'll have a live session wherein students will present a long case for 1.5 hour discussion. With the senior faculties joining the session with a lot of interactions. And also if you join live session, you'll get a certificate, it will be useful for your future career. So please join such sessions, daily lecture, daily MCQs, go through it and give answer. I'll appreciate your answer. And lectures, long lectures comes once a week or twice a week. Please again go through lectures and learn surgery in easier way. And lot of small short lectures are there in my YouTube channel already since last 1 year. Please go through that, it will be very, very helpful for your exam and other things. So we'll start the discussion. Clinical approach to thyroid swelling is a very, very important thing. And history is very important. I'll very briefly, I am telling you, not narrating everything. You can always go through my clinical methods in surgery, current edition with the video examination of thyroid is there in that. And also you can go through my manual of surgery in detail about the thyroid. Very good, extensive, good book with lot of illustrations, photos, detailed principles of surgery, treatment aspect also. The history is age, occupation, residence, everything is important because thyroid swelling often endemic in certain areas. Age is important, younger individual also it can occur, elderly also it can occur, when a neoplastic condition, goiter, toxic thyroid, so many conditions can occur, that's why it is so important. And see that Derbyshire neck, Himalayan goiter belt, they used to get a lot of thyroid swellings in the certain areas. So that's why it's called a Derbyshire neck in olden days. So you can see that butterfly shaped thyroid enlargement in goiter. You see here mainly isthmus area. You can say male patient thyroid enlargement, high risk. Remember, high risk is a male patient and thyroid is enlarged because it is a thyroid enlarged. Any thyroid disease is common in females, but when it occurs in the males, carcinoma has to be thought of. So that's why this is called high risk in male, common in females. It is common in females, remember. And so chief complaints are important. What appears first? Swelling appears, toxic features appears later, features of hypothyroidism, pain, eventually if it is malignancy, features of metastasis. So like that it is organized. So you know that hyperthyroidism, hypothyroidism. So features of that, features of hyper, features of hypo. So that is why we have to concentrate on swelling, of course, and compression feature. Swelling in the neck region, progression, compression features, hyperthyroid or hypothyroidism features, metastatic if you are thinking, suspecting malignancy, differential thyroid cancers or medullary carcinoma thyroid or anaplastic carcinoma thyroid. That's why that's important. See that swelling, pain, in thyroiditis pain can occur, and malignancy when it infiltrates can pain, hemorrhage into the thyroid nodule pain can occur. So these are different causes for the pain. Otherwise usually they are painless. Hoarseness of voice indicates infiltration into the recurrent lanular nerve. Suggests commonly it is malignancy. Duration of hoarseness of voice, recent onset hoarseness of voice after appearance of thyroid swelling. It's very, very significant history. Weight loss is usually thyroid swelling will not cause weight loss. In toxic thyroid, there will be increased appetite and weight loss is very, very significant. High BMR, that's why, because of the high catabolism, so high metabolism as such. So that is why weight loss will be there, even though there is increased appetite. In opposite is in the hypothyroidism and malignancy, metastatic disease, there will be weight loss. Otherwise, weight loss will not be there when it is a localized. So weakness, palpitation, all these features of the tremor, all these features of the hyperthyroidism. Again, lethargy, increased weight, slowness, all those are the features of the hypothyroidism. Remember, hypothyroidism is very, very common in females. 30 to 40% of females can have hypothyroidism. Only if you do the thyroid function 30, 34 TSH, and free T34, will be able to identify such hypothyroid status initial period. Eventually, of course, mixed edema, late stages, it's very, very typical with obesity, thickened skin, all other features, very, very typical. Remember, thyroid is the only endocrine gland which is properly accessible clinically, only gland that can be involved in all age groups, only gland where malignant tumors are mostly non-functioning. So this is a very important dialogue as far as thyroid is considered. Remember, so I'll put it in a table, history of present illness, posterity, all those things, because a chart I am putting, I'm not going to detail anything. You can always go through my SRB's clinical method in surgery, very detailed history, and also manual of surgery gives an explanation for that. So swelling is the first thing you have to remember always, duration, mode of onset. Very slow progressive swelling can occur in goiter, multinodular goiter, very progressive. Again, papillary carcinothyroid is very slowly progressive, maybe many times it years, few years, 3 years, 4 years, 5 years. And again, remember, papillary carcinothyroid can occur in younger age group, middle age, late age group also. Age is not a criteria. This way we used to say, at least our professor used to say, tell, any thyroid can be malignant unless proved otherwise, independent of the size of the swelling, independent of the age of the patient, independent of the duration of the swelling. So that is the point which always you have to remember. You have to rule out malignancy. There are current criteria are there, guidance are thyroid association guidance are there. You don't require to do surgery in every patient. These are the criteria which are there. That is later you can understand. This is what we are discussing is basically a clinical approach. So pain, so origin, nature, character, duration, when it started, severity, aggravating early factors, I have already told. Thyroiditis, tumor necrosis, hemorrhage in a nodule, rapidly increasing the size. In such a situation, it will become a pain, there will be pain. Fever, of course, in a thyroiditis, sometimes in a hypervascularity, situation fever may be there. Other lumps and started progress like neck nodes. So thyroid swelling is there. Eventually, if it is a differential thyroid cancer, especially papillary carcinothyroid, it's got a very high affinity for neck cervical lymph nodes, 2, 3, 4. They are secondary lymph nodes. Primary thyroid lymph nodes are in the 6 pretracheal, laryngeal, pretracheal, paratracheal lymph nodes. They are level 6. They are primary lymph nodes. They're clinically very difficult to palpate those lymph nodes. Whereas secondary 1, 2, 3, 4 neck nodes. If it is involved, probably so that they'll say thyroid swelling neck nodes are there. Sometimes the thyroid may not be palpable, only neck nodes will be palpable. They call occult thyroid with the secondary in the neck. Not uncommon, remember. So one of the causes for secondary in the neck may be thyroid, which is a primary, which is not clinically visible or palpable. Skull, because skull secondaries in the follicular carcinothyroid is quite common. So skull any swelling appear, that is important. Sometimes occult follicular carcinothyroid can have skull secondary. They present with the skull secondaries. This is also important. Their pulsatile skull secondaries are very quite specific as far as skull is considered. Pressure symptoms, I already told, stridor, dyspnea, hoarseness of voice, dysphagia, duration. That indicates infiltration or maybe compression. Long time thyroid may cause difficulty in breathing because the thyroid cartilage get weakened. Where Cocker's test, when you compress, they get stridor. Stridor at rest is a sign of infiltration. Stridor on compression through Cocker's test, it is sign of compression. Where cartilage get weakened. Same causes may cause dyspnea also. It may be due to compression, it may be due to infiltration by malignancy. The two causes why pressure symptoms can occur. Whereas hoarseness of voice is most of the time due to carcinoma only. It recurrent has to be infiltrated by the thyroid. So it's very significant, very specific clinical finding, hoarseness of voice, suggests malignancy. Symptoms of toxicity like metabolic changes, neuromuscular changes, severe genital, visual, skin changes. All those things are there, skin changes, pre-tibial mixed edema, all those things are quite significant. You can always go through my book. What are these different symptoms, toxic features, which is very important to identify in such patient. So symptoms of hypothyroid, slow, lethargic, bradycardia, dry skin, and increase in weight, gain weight. All those things are the typical features of hypothyroidism. Family history, family tree, 3 generations, very, very important. Thyroid disease may run in family, so need to know. And history of tuberculosis, diabetes, malignancy, the usual thing. Treatment history, again you have to ask in the family members having a thyroid disease, that's important. What type of disease, for what they have operated. So medullary carcinothyroid runs in family. Other malignancy also can run in family. Some goiters also, because in endemic area, goiter can occur in the family where deficiencies are there, thyroid hormone deficiency or thyroid iodine deficiencies. Person is taking appetite, weight loss, diet, positive swelling, previous history of disease, spinal disease, tuberculosis, diabetes, leprosy, again, positive treatment. I already told, drug intake. Many times they take thyroxine because it's very common, remember. Hypothyroidism is a very, very common entity. And they take drug, thyroxine. Unless you ask, they will not tell. Usually 25 microgram, 50, 100 microgram. Usually once a day, empty stomach, early morning they take. So if you ask the history, then they will say, they will show that bottle, it comes in the bottle. So what medicine they will show this. So better to ask the specific history. Sometimes they'll take antithyroid drugs, maybe methimazole, maybe carbimazole, and so on, for toxic thyroid. So that's also important. Any other drugs which cause a thyroid disease. Some antipsychotic drugs, cardiac drugs also can cause thyroid disease. That's also important, which drug they are taking and how it is relevant for as far as thyroid disease is considered. That is also important to understand. Menstrual history is important. They may be having menorrhagia, they may be having amenorrhea, hypothyroidism, and obstetric history is important. How many children, is there any problem, parents, siblings, parents, siblings, 3 generation, children, how they are. 3 generation history is important in family history. That's very, very important. And once you take in a very clear history, you have to make a summary of the history, not mentioned here. Any long case, mention the summary of the history, brief. Then go to the general exam. The next is again important in thyroid, anemia, jaundice, clubbing, all these things. Eye signs are very, very important. Remember, there are so many eye signs are there. What you have to remember is Stellwag sign, Van Grief sign, Geoffroy sign, Nafziger sign. Then, of course, Mobius sign. Stellwag sign is like this. You look, if the eyelid follows your finger when patient has to look downward, that is normally can't follow, that is positive. Mobius sign is from distant ask the patient to converge. Convergence refractive means that is probably eye is involved in toxic thyroid. Ophthalmo may go for ophthalmoplegia eventually. Then Geoffroy sign is ask the patient raise like this. I will show the photo later, like this. Then if you can't raise this one, then it is positive. Nafziger sign, behind see the patient and see the level of the eye, front of the eye, bulb of the eye. If it is visible, that means there is exophthalmos. There are the 4-5 signs you have to remember. For academic purpose, there are 20-25 signs are there, which is not necessary for you. But these 5 signs you have to remember. Stellwag sign, starry look, Stellwag sign, Van Grief sign, Mobius sign, then Geoffroy sign, Nafziger sign. I'll show the photo how to do it later. So just remember these things I already mentioned. Tests for ophthalmoplegia, like this. Movement of the eyeball. If you do like this, if a patient is able to do that, eyeball is normal. So this is general examination. So local examination is also important. It's very relevant. Tests are, so many tests are there. In the exam, you are supposed to demonstrate how to do that. You should have very, very clear-cut idea how to do that. So I'm putting the inspection in a table. Most important is a swelling. Location important. From the bony point, lower part, and from the sternocleidomastoid muscle, and relevant to the thyroid cartilage you have to mention. It's a butterfly shape. So from one lateral to other, you have to mention as a single swelling. So where it is located, how far it is from the sternum, how far from the mandible, then laterally how far it is related to the sternocleidomastoid muscle. So exactly you have to mention. You can give a measurement in vertical and horizontal clubbed together, both lateral lobe and isthmus. After that, you can individually say right lateral lobe is this much length and width, left lateral lobe is this much length and width, and isthmus is. So it is a single entity, remember. Entire thing you have to give a mention first. Then individually you can categorize and tell. Individually right lateral lobe is different, dimension is like this, left lateral lobe dimension is like that, isthmus is like that. But beginning always single entity, entire thing. Like this, entire thing you have to show the measurement. And girth also important, neck girth. To serial, if you examine, do a follow-up, neck circumference is important. So again, size, shape, extent, color, surface, dilated veins. Why dilated veins in toxic thyroid? Toxicity increases the circulation, vascularity. So that malignancy also can have increased vascularity or venous blockage can cause the dilated vein. Or if there is a retrocessional extension Pemberton sign is like this, you raise like this. So ear, arm should touch the ear. So that is how exactly you will do it. That photo I'll show you later. Now what is most important, of course, edge margin of the swelling. Lower border is very, very important, thyroid. If lower border is not seen, not visible, that means there is extrusional extension. While you put the finger like this, ask the patient to swallow, then you'll be able to feel clearly lower border. If you won't be able to clearly see the lower border, then it may be extending to the extrusional extension. That is in patient and palpation also you have to do. Palpation, you put the finger. Movement of the deglutition is most important. Why thyroid moves with the deglutition? Because at your level, UG level, there is no require to a detailed thing. There is a posteriorly, there is a condensed deep fascia, so pretracheal fascia posteriorly in the upper part, which is attached to the cricoid cartilage, and it is attached to the cricoid is attached to the muscles there, constrictor muscles there. So while doing deglutition, constrictor muscles will contract, and so cricoid is moves upward because pretracheal fascia is enclosing the thyroid. So posteriorly condensed pretracheal fascia, that is called Berry's ligament. Superiorly, medially condensed. So very close to the. Another significant of Berry's ligament is it's very close to the recurrent annular nerve. So it's a landmark during surgery on table to identify recurrent annular the Berry's ligament. So it's two significance are there for Berry's ligament. So it's a condensed posterior part of the pretracheal fascia, superiorly, medially, which is very important. Which is how, because of that, thyroid moves upwards of deglutition. Give the patient a half cup of water, ask the patient to drink, then see the movement of the deglutition. Very, very most important clinical test is movement of the deglutition to say it is thyroid. There are certain exceptions where if it is infiltrated, it will not move with this one. Anaplastic infiltrated will not move. And reduced thyroids may not move with the deglutition. Very large thyroid, there is no space, may not. There are exceptions. But by principle, thyroid will move with the deglutition. It's what as an undergraduate you have to remember. So the test is give a cup of water, ask the patient to drink, observe the movement of the thyroid upward during deglutition. That is the most important. All other things, of course, edema, dilated veins. Pizzello's method is like this. Make the neck prominent. That I'll show the photo, especially in short neck and obese patient. Pizzello's method for inspection also, you do in the palpation also. WHO grading of the goiter, no visible, no palpable goiter. One is palpable goiter, but no visible. So it's palpable and visible both in the neck in normal position. Okay, this is the WHO grading of the. There's a modification of that. You can always go through my book for that. And inspection is over, palpation. Again, same like a swelling, local rise of temperature, tenderness, then size, shape, then measurement, horizontal, vertically and horizontal, both lobe, then individually different lobe. That also I already told. On surface, smooth, nodular, then margin, lower margin is important. Then consistency. After surface, you have to tell consistency, whether it is firm, hard, or variable. Some may be firm area, may be firm, some may be hard, some may be soft. Don't tell the soft to firm to hard. If it is like that, tell variable. Right side firm, left side hard, system is soft, like that. Where it is soft, where it is firm, where it hard, like that you have to tell. So the consistency is important. Then again confirm movement of the deglutition. Always initial palpation, inspection should be done always in front, in the patient in sitting position. Palpation initially, in patient is in sitting position, you examine will be behind. We put the both thumb over the occiput, external protuberance, then feel the neck, patient will press the neck and feel the thyroid. That is the correct method, initial method. Wall feel, lateral lobe, isthmus, movemental rotation, surface, nodularity, everything. Then come front, then feel with the thumb. That is the Kreil's method of examination of the thyroid, where all nodules with the thumb or the finger, tip, pulp of the thumb, pulp of the finger. Feel all part of the lateral lobe, for how many nodules are there. That is Kreil's method of examination. Then examine the trachea. That is like this, 3-finger test. Trail sign is if in a solitary nodule thyroid, one lobe is involved. If it is pushed, then hollowness opposite side will be lost. So that is the trail sign. That is very important. 3-finger test is important. Lower margin is important. Leahy's method of examination, especially one nodule is there, to say that the posterior part of the gland, nodules are there or not, to find out. Push the lobe like this. Then the trachea rotates like this. So posterior becomes posterior lateral. Then opposite side feel laterally. If there are nodules, then you say that it's a nodular multinodular goiter. So initial your clinical diagnosis of solitary nodule becomes multinodular goiter. Same thing you can do open the opposite side, push like this. Then one nodule is there here. Then posterior becomes posterior lateral. Then you can feel the laterally. You can see the multiple nodules that becomes the multinodular goiter. Current international definition is ultrasound is sonology is a part of the clinical examination. So if you consider sonology part of clinical examination, all these tests will not have any significance. Pure clinical examination, if you say to differentiate solitary nodule and multinodular goiter, Leahy's method of examination is very relevant. Fluctuation, phase state you can do, or 3 or 2 finger test you can do. Translumination, some cystic swelling may be transluminant. Pulsation, thrill is important, usually checked in the superior pole. You know that superior thyroid artery, even that supplies only 1/3 of the gland, it enters the gland superficially, whereas inferior thyroid artery enters from the deeper plane. So any hypervascularity in toxic thyroid malignancy, if there is more, especially in toxic thyroid, it's a very relevant toxic thyroid. If you feel in the superior pole in front, you can feel the thrill. Same when you auscultate, you can hear a bruit because of the hypervascularity. So that is why it is important in the superior pole. It's very important. Remember, plane of the swelling is again important. So the key muscle in the neck is sternocleidomastoid muscle, like this. From the mastoid to the sternum, it runs like this. Okay, and it holds the neck. And so this muscle has to be contracted to see that, because you know deep fascia from front goes like this backward, and closer the sternocleidomastoid muscle goes backward, and it has the attachment. Posteriorly becomes the prevertebral fascia, and around the thyroid from the tracheal fascia. So around the carotid from the carotid sheath. That is briefly how investing layer of the deep fascia is anatomically arranged. And so sternocleidomastoid muscle is within the deep fascia. So when you contract sternocleidomastoid muscle, like this you can turn to opposite side, see the one side, or like this, contract both sides, you can see both sides. Then if it is deep to the thyroid, you will be able to see that and confirm that it is deep to the deep fascia. All other putting tongue like this, all those not much significant. When contracting platysma, that's all not much very useful. It's very difficult to check. Checking the contracting the sternocleidomastoid muscle and checking the thyroid location is the most important thing. And of course, movement to the deglutition, then lower aorta, trachea, thrill, then carotid examination. Carotid means common carotid artery, ethylylothyroid cartilage, medial to the sternocleidomastoid muscle. You can see the common carotid artery. Now, over which you know that any artery should be palpated over a bone, like femoral artery over the neck of the femur, radial over the radius, dorsal pedis over the navicular bone, like that. So here also over the bone, it is not that you can't feel the bone. Over which bone? It is academic interest. So there is a lot of debate on whether you should tell Chisagnate tubercle or the transversus fossa or discus vertebra. It is an existing entity, Chisagnate tubercle. You can't clinically feel it, but you palpate over that. There is an academic interest. So many times examiners will question you how you know Chisagnate tubercle. It is wrong to question. It is accepted one. It is not you are palpating the Chisagnate tubercle. It is academic, like femoral artery is felt over the neck of the femur. It is not you feel the neck of the femur and then palpate the femoral artery. When you palpate naturally posterior surfaces, you should have a strong bone. You never palpate the bone and feel the femoral artery, any artery. It is the academic part of whatever it is located. So there's a clear-cut answer for whoever questioning this Chisagnate tubercle. Anybody, this is the clear-cut thinking. You should remember. You are feeling the femoral carotid artery over the Chisagnate tubercle in the transverse of the C6 vertebra. You are not examining the identifying the Chisagnate tubercle. There is no need. So that is what I might take for the Chisagnate tubercle and palpation of the common carotid artery. And planar swelling I said. So there is often MCQ question. Remember Chisagnate tubercle over the transverse of C6 vertebra. Superficial temporal artery has to be large thyroid. If the carotid artery is not felt, then whether there is a superficial temporal artery, if you feel, if it is palpable, still arterial perfusion through the artery is there. If it is not palpable, it is fully encased and blocked. So if it is, carotid is not felt, superficial temporal artery should be examined. That's the reason why I have put superficial temporal artery. So other examination is important. Oral cavity, maybe Lingual thyroid will be there. So that's why you have to examine percussion over the sternum. This is called direct percussion, whether it's recurrent or dull. In retrosternal goiter, it will be dull. Normally, it is recurrent because trachea is there. Indirect method is percussion finger and pleximeter finger. This is painful, but this is ideal. But this is less painful, but you are percussing bone over the bone. Both are in many books, both are accepted, but standard is direct percussion, but both can be accepted actually. And auscultation, bruit over the swelling, I already told, superior pole. Or carotid, because there is a narrowing, you can always see. Cervical lymph node exam is important. Always examine one side first and other side. Usually here 1A, 1B, 2, 3, 4, 5. 6 is difficult to palpate because even though they are primary lymph nodes, are commonly involved in the thyroid. In thyroid, 2, 3, 4. 2, 3, 4 is the most important thing, common lymph node, not 1A, 1B. But when you examine, always examine all levels. One side first, then other side. Don't palpate cervical lymph node both sides together. There is not a standard proper method of examination neck nodes. One side first, then opposite side. That is important thing. And systemic examination is important, abdomen for hepatomegaly, because toxic thyroid, malignancy hepatomegaly can occur, spread. Toxic thyroid hepatosplenomegaly can occur because Graves' disease, and Hashimoto-thyroiditis hepatosplenomegaly can occur. The examination is important. Then bone examination, especially frontal bone, for metastatic disease in differentiated thyroid cancer, specifically follicular carcinoma thyroid. So that's why that is important. CNS can be involved in the toxic thyroid. Trimmer will be there, hand trimmer like this. So put your finger of pen or paper, then you can see the outstretched hand. Trimmer is very important for the toxic thyroid. Then jerks, ankle jerk, knee jerk will be aggravated in hyperthyroidism, slow in hypothyroidism. Skull and spine, I already told. Respiratory system also important. So all these systemic exams are very, very relevant as far as thyroid examination is concerned, because related. The respiratory is related, is related important. You can see the lingual thyroid in the posterior third of the tongue. See, usually in such patient, thyroid fossa is empty because thyroid is not descended downward. So empty thyroid fossa clinical is very important. Again, you have to do T3, T4, TSH and see whether it is functioning or not functioning. So skull examination is important. See, thyroid swelling, skull examination. Follicular carcinoma thyroid causes secondary, especially in the frontal bone. That is pulsatile secondaries. Respiratory system auscultation is also important because lung involvement. Cardiac system examination. It's a cardiac system, it's a respiratory system. Important because toxic thyroid, tachycardia will be there, collapsing pulse will be there, ectopics will be there. So association. So cardiac system, respiratory system also important in this patient. Okay. So here you can see CT scan, thyroid you can see primary, secondary here. Again, operated follicular carcinoma thyroid, second is in the skull. So here is the common side, here are pulsatile secondaries because it contains colloid, both outer tubule and inner tubule as involved. So brain pulsation and vascularity both will increase because there is a new angiogenesis. There is a vascularity is very high. And of course brain pulsation also transmitted. So that is why they will have a second is in the skull. So clinical diagnosis, I will put all this way you can put multinodular goiter, non-toxic, toxic right side, properly should write. Euthyroid, status, second is neck lymph node, whatever happened. So entire thing you should write like this very clearly, should very, very clear. Side, nodes, toxicity, everything. This is exactly you will write this one. So how we will manage? Again, investigations, different investigations, clinically of course, quadruple evaluation, quadruple assessment. In breast triple assessment, here quadruple assessment, clinical examination, biochemical examination, sonological examination, then FNAC, cytological examination. Clinical, biochemical is the T3, T4, TSH. Sonological is important. Usually clinical, sonological, biochemical, clinical, biochemical, sonological, cytological. After sonology, you do maybe ultrasound guided FNAC also. There are the four things: clinical, biochemical, sonological, cytological. That is FNAC. So the four. That is quadruple assessment, clinical, biochemical, with the T3, T4, TSH, sonological, ultrasound, and cytological, FNAC. Then of course treatment, different strategies are there. We are not going to discuss that one, but this is the orderly fashion. We should have we should have a summary after history. We should have a final summary before clinical exam. There are two summaries we should have in a long case. And brief evaluation, brief treatment strategy you would write always in the long cases. So this is how exactly you will write the. So I just go through these things, inspection, neck, you have to inspect all round, that's important. See that this is a movement in the deglutition. Give a cup of water. So this is a posteriorly, pretracheal fascia is condensed, tough it is posteriorly. Surgical capsule, true capsule, surgical capsule, you have written pretracheal fascia here. This is the suspensory ligament of Berry. Tough it is. See that pretracheal fascia. See how exactly it is located here. See that pretracheal fascia here. So just a diagrammatic show how exactly this pretracheal fascia is located within and includes the thyroid, where Berry's ligament is very thick posteriorly. So this is important, movement with the deglutition. So this diagram shows what is the meaning of the pretracheal fascia, what is the meaning of the Berry's ligament, what is the surgical significance, both in clinically and on table it is important. So difference is that male thyroid is important, butterfly shaped, solitary nodule, multinodular goiter. See that solitary nodule in a male, maybe malignancy, you have to think of high risk. See the toxic thyroid, diffuse toxic goiter, probably primary toxic because the exophthalmos is there. Colloid goiter. See that malignancy, skin involvement, skin is involved, everything. Probably anaplastic. So anaplastic, colloid, toxic thyroid, solitary thyroid in the male, malignancy in the male, butterfly shaped goiter, isthmus involvement, multinodular goiter, all types of how exactly. Just this picture is this one, how exactly different conditions look like. So the moment you look at these things, you will be able to give you have a clinical intuition about the condition as such. So the picture is very important. And Pizillo's method, this is how exactly will do that. Leg will become prominent. And fix it to the skin is important. Again, remember, palpation. This is how I said, thumb should be felt over the external occipital protuberance, and front should be, patient should be sitting in a stool. You are behind, a clinician is the behind. See that? So this is the beginning of the palpation, always should be like that. And see the Kreil's method with the thumb. And measurement, see that? Measure vertically and horizontally like this. And circumference you have to make. Plane of the swelling, I said, sternocleidomastoid is the key muscle. And skin pinch it is the skin pinching. And circumference, this is the trachea, 3-finger test. I said trail sign also, opposite side, sternocleidomastoid become prominent. And thyroid thrill, you have to palpate, carotid palpation, how exactly, see that, see these things, how exactly you will do. So all these things are important when you examine. Lower border examination is very crucial, see that, very crucial, lower border examination. Pemberton sign already shown. Arm should touch the ear, very close to the ear. And then see whether it dilated veins in the neck, chest wall, because if there is external extension, thoracic inlet is compressed. So superior vena cava is compressed, and they'll have dilated veins. And sometimes they'll have a compression occurs over the trachea also, they'll have dyspnea, occasionally dysphagia. Main thing is dilated veins, and they'll become dyspneic. So this area should be exposed actually, above the nipple area, upper chest and neck, everything you should expose actually when you look for the Pemberton sign. But the Cocker's test and Pemberton are condemned because suddenly they may collapse. So in a given patient, whether you will do it or not, you should be very careful because sudden patient may collapse. So these two tests you should be very, very careful. Remember, Cocker's test and Pemberton sign. So this is the extension. See that once your neck, once arm is extended like this, see that this is what exactly happens. Arms down, arms up, see that dilated veins. So this is the picture of exactly retrosternal extension occurs. See that? This is of exactly retrosternal extension occurs here. See that image, see the image it going down. See the same thing, before arms up and after arms up, dilated veins. Same thing, without arms up, with the arms up. So very, very, very typical. So Cocker's test is the compression of the both lateral lobe, posterior medially equally, gently. So it is a sign of compression in a long-standing thyroid, large thyroid. It continuous pressure over the tracheal cartilage. You know, the trachea is a C-shaped. Front is the cartilage and C-shaped cartilage, and posteriorly trachealis muscle. It's not round. And semicircle it is, half circle. And trachealis muscle is soft. And once, because thyroid is here like this, so thyroid, because of the long-standing thyroid, keeps the compresses over the cartilage and weakens. But it itself keeps because thyroid falls is a forward direction. It's a direction forward. So it keeps the tracheal ring patent. So, but when you compress like this, it collapses. Tracheal ring, stiff tracheal ring is weakened. It collapses over the trachealis muscle, and patient develops stridor like that when you compress. like that. But that is a sign of compression, not a sign of infiltration. And such a patient, when you do Cocker it becomes positive. Such a patient requires a tracheostomy after total thyroidectomy. Usually tracheostomy is for 2 to 3 weeks. After 3 weeks, because there is no compression, tracheal rings regain its strength and function normally. Tracheostomy can be closed. So tracheostomy is never a permanent entity in tracheomalacia. When there is a positive Cocker test, which is a sign of compression, which is not a sign of infiltration. Sign of infiltration is malignancy infiltrated the thyroid, they will stridor. Stridor at rest. Patient walks with the stridor, thyroid swelling, few thyroid swelling, comes to the OP with the like that, without touching, without clinical examination. Whereas a sign of compression, Cocker is on a clinical examination only. And you don't press, it doesn't cause any stridor. So you should know the difference between the sign of compression, Cocker test, and sign of infiltration, stridor at rest, that is. So these are the two different concepts which you have to remember how exactly you will do it and what is the clinical approach, clinical implications of these tests. So Leahy's method already told, press over one side, trachea rotates. So posterior becomes posterior lateral, then field, then for the nodule. And mobility of thyroid. Thyroid does not have an independent mobility, remember. Thyroid moves along with the trachea. It moves upward during degradation. No independent, unless very small, very mobile nodule, sometimes maybe mobile independently. Otherwise, there is no independent mobility for thyroid as such. But it moves along with the trachea, it moves upward during nutrition. So this is the exact meaning of the mobility. Don't tell thyroid moves independently. So cervical lymph node examination is important. See that both neck nodes you have to examine, mainly one side first, opposite side first. 1, 2, 3, 1A, 1B, 2, 3, 4, 5, but mainly 2, 3, 4. Neck to say whether it's a metastatic disease or not, because node is very commonly involved in papillary carcinoma of thyroid. And remember, commonest thyroid carcinoma is papillary carcinoma of thyroid. That's why neck node should be examined. And systemic examination also important. Check the pulse and BP, because in toxic thyroid it's very relevant, and collapsing pulse also. And toxic signs, all signs need not remember. Hand tremor, how to check. And Von Grief sign like this. Put the finger, ask the patient to follow and see that how exactly you do that Von Grief sign. Mobius sign, convergence. Inferior rectus and lateral rectus will be involved. Convergence sign difficult. Medial rectus, inferior rectus. And there's a sign of early ophthalmoplegia. The Navziger sign from behind, see the this one protrusion is there or not. Your eye should be in line with the eye of the patient. And see, this is exactly Navziger sign and Geoffroy's sign. See that Geoffroy's sign. Flexed and wrinkle like this, not like this. Absence of wrinkling, typical of the toxic thyroid. So Geoffroy's sign, Von Grief sign, Mobius sign, Navziger sign, and hand tremor. So the signs which are Stellwag sign is tarry look. There is on inspection, not eliciting. And these are the signs only we have to remember. And Stellwag sign I already told. So look for pre-TPL mixed edema in toxic thyroid. It's a mixed trauma, remember, toxic thyroid. It is a mixed somatous deposition in the leg and ankle, both sides. So always inspect this area in a toxic thyroid, extrathymus, this area. So percussion over the sternum, it's a direct method, indirect method, all those things I have told is important. Auscultation, bruit is important. In the superior pole, always bruit. And remember, these are the things which you have to remember always. Functional status, compression, neck node, trachea, carotid deviation. Carotid can be deviated, carotid can be infiltrated. Where absence of carotid pulse. Berry's sign it is. Berry's ligament, Berry's sign. Berry picking is not done now, not used now. Berry's sign is malignancy infiltrating the carotid sheath. So carotid pulse is not felt. Carotid in the large thyroid, carotid may be pushed posteriorly. Displacement. That is not compression, that is not infiltration. Till it is felt. If it is encasement, then you have to look for the superficial temporal artery, because still percolation is there or not, perfusion is there or not. Features of malignancy, neck node, skin involvement, stridor, immobility, all those. Retrosternal extension is important, I already told. Lower border, percussion, Pemberton signs, these are the clinical signs. Cardiac, abdominal, respiratory systems, I told, toxic thyroid, malignancy, hepatosplenomegaly can occur. Because grave disease and Hashimoto thyroiditis are immunological related diseases where hepatosplenomegaly is common. Bone is second in the frontal bone, I have told. Kreil's method, I said. Kreil's grading is for pulsation, grade 1, 2, 3. Other tests, T3, T4 is the free T3 for serum. Calcium is important, remember. Ultrasound neck. It's the most important thing is currently is ultrasound. FNA thyroid, indirect laryngoscopy, now of course, stroboscopy will do, where direct imaging of that voice, you can check video recording of the voice. Not ILS, is the indirect laryngoscopy. It's the olden method. Of course, still will be asked in the exam how to do what word E will tell. You have to dip the indirect laryngoscopy in a warm water, then pull the tongue out and see the vocal cord. Ask the patient E, abductor of the vocal cord, then see the abduction. Thyroid antibodies, you have to remember. X-ray neck for calcification, radioactive adenine 131 study or technetium 99M study is important. This is only for study, this is for therapy also. MRI neck, CCT neck, again it is important. Serum thyroglobulin is a very good marker for carcinoma, differentiated thyroid cancer. It's a very important marker. Again, a short note, just to go through what is the normal value, why it is significant, everything. TSH is important. TSH, thyroglobulin, that's why I said quadruple evaluation, clinical, biochemical, sonological, FNAC. So in this patient, CT you have to do, skull. So again, remember thyroid, steel, patient, because when you enter the OT, patient have tachycardia, all those things. So every day you take the patient to the OT, today, tomorrow, that tomorrow, and suddenly, then after 3-4 times, patient thinks that today also I am coming back, so no worry. So tension is, stress is reduced. So suddenly that point of do the surgery. It's called thyroid steel. Thyroid paradox is cystic swelling is hard, solid swelling is soft. That is in a malignancy, tumor cells will be softer, sometimes rapid proliferation, whereas intensely cystic swelling becomes firm or hard. There is thyroid paradox. That is very typical. Lateral aberrant thyroid is a misnomer. It is not thyroid, it is a lymph node. Secondaries in papillary carcinoma thyroid, usually occult papillary carcinoma thyroid. There is no lateral aberrant thyroid entity, it's a misnomer, remember. It's often asked as a short note, small short note. Different tests are told, different eye signs are told. Causes of rapid increase in the thyroid, recent hemorrhage, benign turning into the malignancy, multinodular goiter turning into the follicular carcinoma thyroid, papillary carcinoma thyroid, long-standing turning into the anaplastic carcinoma thyroid, recent increase in the size, hemorrhage, all those things are the causes. Anatomy of thyroid, lymph node, primary gland, prelaryngeal, pretracheal, paratracheal, neck nodes. There are secondary nodes, there are primary nodes. Delphian nodes. Delphian node is a single node between the true cricothyroid. Understood? So it is actually considered a sentinel node for the thyroid. So sentinel node for that is the Delphian node. Prelaryngeal between the true cricothyroid muscle. One node it is in front. Parothyroid glands, you have to remember. Rectal is very important, crucial. Berry's ligament, Berry's sign I have told. Cerebrocyst is another entity. Lingual thyroid is one of the common congenital anomaly. Pre-table feature of a toxic thyroid, not misnomer. Exothermus causes goiter. Goiter classification and differentiated thyroid cancer. In thyroid neoplasm classification. Dunnell classification, you have to remember. Differentiated, undifferentiated, anaplastic, and lymphomas. Secondaries. That is how exactly classified. Always, you can read my manual and clinical book for details. My DigiNow lecture through JP Publishers. All 220 lectures are there in that, and everything surgery is covered, including examination, X-ray, instrument, specimen, brief operative procedure, all topics, general surgery, specialty, gastro, everything, neurosurgery, urology, cardiothoracic. You can always purchase for 1 year and learn surgery entirely with my lectures. So that's a DigiNow lecture, my manual and clinical book. It's very good for learning surgery as such. So examine thyroid all around is very important. See that thyroid looks correlated, specific specimen. See that cut section, classification, everything. So another person you have to remember all is Emil Theodor Cocker, who was from Bern, Switzerland, 100 years back, did extensive work on thyroid surgery, who was the one who designed thyroid incision for thyroidectomy, thyroid pedicles, technical aspect, everything, with the 100 years back, with the least mortality at this time. Because that is Switzerland was the goiter bed that point at large goiter like that. It did so many thyroid surgeries and saved the life with the least mortality. He is the father of thyroid surgery, and he got Nobel Prize for that. He is the first surgeon to get Nobel Prize. Emil Theodor Cocker. There are so many other Cockers are there. So many other Cockers. You know the Cocker's Wien, Cockerization, Cocker's test, Cocker's instrument, Cocker's forceps, the tooth. Then Cocker's method of shoulder joint dislocation, posterior dislocation. Cocker's many incisions are there around. Right subcoccygeal incision for gallbladder is a Cocker's incision. So many Cockers are there. Cocker's, Theodore Cocker, maybe a short note for you. Remember this person. Excellent, did a lot of work for surgery in general, thyroid in specific. That is Emil Theodore Cocker from Bern, Switzerland. So just see the video of the thyroid examination. Just see that inspection all around, important, lower border. See that? Side, neck areas, back, different levels, entire thyroid, lateral lobe, trachea, everything. See that? That's important, how to inspect all around. Then ask the patient to drink water. And Pizzolo's method, that is. Thumb should be placed over the external occipital protuberance. Measurement. Entire gland should be measured, remember. After the circumference, when you are not operating, when you are monitoring the thyroid swelling at regular intervals, maybe after monthly, then measure and keep it. Kreil's method, lower border is important. Skin pinching is important. Plain. Sternocleidomastoid contraction is important. See that? Either one side. See the sternocleidomastoid, whether it's a deep toe or not, or both. You can put it like this. I've shown already. Pizzola's method again for palpation. Then Clay's method of Ex-HOD, Clay's test or method, both. See how it's rotate the thyroid by like this and rotate it. Push it rotates and posterior becomes posterior lateral. Take a 3-finger test, tracheal palpation, again important. Cocker's test is important. Pemberton sign, see that I already shown. See dilated veins and other things. So arm should touch the ear, that's important. Extending the arm above the shoulder. Carotid pulsation, I already told, at the left thyroid cartilage, medial to the sternocleidomastoid muscle. Thrill also I told. This is thrill palpation. Neck node lymphoma, 1A, 1B, 2, 3, 4, 5, 6. Percussion, direct method. Some people say indirect method also. Direct method is the ideal thing. Both can be done, of course. Auscultation over superior pole of the carotid for Brugge, that's important. Skull and spine examination, important. Skull for the frontal swelling, secondaries. Rotation of the spine should be done in sitting position. You have to fix the pelvic girdle, remember. If you do in the standing position, that is wrong. Sit in a stool and do. Respiratory and cardiac system. Cardiac system is important, respiratory system is important. Abdomen, hepatosplenomegaly, that is important. Abdomen examination. Ankle jerk, knee jerk, it's exaggerated and toxic and less in this one. PT, but fixed edema, how to check. General examination is important, pulse, BP, and other things. I put it in the last, what issue is important again. Looking for eye signs also important. Tremor, hand and tongue tongue should be inside, not outside. Not like this. Some books I mentioned wrongly because it won't be able to see the fasciculation. Wrong method, see, wrong method. Right method is always tongue within. So blood pressure, important. Eye signs, that is one grip sign. Already told. Patient follow, it doesn't follow, it's just toxic thyroid. MBBS sign, convergence. Half-right sign, ask the patient wrinkle like that. Plus and 2, important. And this is Navziger sign, like this. Navziger sign, see the line. And of course, another video of the malignant thyroid, large one, big one. So we have operated, it was involved, we did tracheostomy in this patient. A transfusion of blood also. It come as malignant thyroid, follicular carcinoma thyroid. See that thyroid, how it looks like. Again, palpation, everything should be done same way. Large thyroid, see that? Vascularity, nodule, everything, visible veins are there. She find difficult to extend actually. Movement with nutrition is a movement with the putrescence of time for thyroid cyst, not for any of these things. Hold it, open, hold, then go to the tongue. Tug-like feeling, it's a very typical of thyroid cyst, remember. That means thyroid cyst not for usual thyroid is not necessary to do that. Tug feeling. One more, just quickly, I will not give anything. Just on male patient, important, so I'm just showing it. Male thyroid examination is the same. Movement with reduction, Pizzolos method, putting a thumb behind and doing. Measurement. Individually and entire thing you can measure. I already told. Kryle's method. Plane of the swelling, important. Sternocleidomastoid muscle contraction. Both like this. Lower border is important. Three-finger test. Cocker's test. Again, Cocker's test. Pemberton sign. Look for dilated veins. Neck node examination. Other area to examination. Leahy's method of examination. Thrill. Carotid pulsation. One side you have to examine, then other side. Don't examine both sides together. neck nodes 1A, 1B, 2, 3, 4, 5. First one side, then other side. This is this is for thyroid cyst actually. How to do tugging? I just want to demonstrate. Not necessary for any traditional thyroid swellings. Direct method percussion. Indirect method, ideally direct, remember. Auscultation for thrill. Bruit, sorry. Palpation for thrill, auscultation for bruit. Both sides. For vascularity and toxicity. Toxic thyroid. Skull for the secondaries. Spine. Spine tenderness, deformity, paraspinal spasm, spine movement, rotation in sitting position. These are the things. Respiratory system, cardiovascular system you have to check. Pulse you have to check, BP you have to check, pretable mixed you have to check, ankle jerk, knee jerk you have to check. This is of course Pizzolo's method, just wanted to show how exactly to be done in short neck and obese patient. Pulse and collapsing pulse. Hand trimmer like this, extended this one. One grief sign, MBBS sign, or movement of the eyeball, ophthalmoplegia to check, important, like this. Joffroy sign, wrinkling. Navziger test. From behind you have to see, line should be like this, alignment. Eyeball should be in same line. So students have my SRB's manual of surgery, current edition for retail. Everything surgery is covered as per CBM syllabus with illustrations, photos, footnotes, quotations, with management policies, principles, everything. Everything is covered. General surgery, specialties, gastrosurgery, urology, neurosurgery, cardiothoracic, instrument, operative surgery briefly, anesthesia, imaging, everything is covered. It is sufficient for you to learn surgery. And with my clinical methods in surgery, current edition, each chapter in detail, examination method, lot of photos it is shown, principles of examination also shown with the differential diagnosis in a tabular form, with the brief videos of the examination of the each method, like hernia, thyroid, breast, abdomen examination, swelling examination, ulcer examination shown, varicose vein, arterial disease, so on, which is important for your exam. And it doesn't contain my treatment aspect because it's a clinical exam book. It contains specimen, instruments also. So briefly orthopedic examination also. So have my clinical methods in surgery. It's the best book, actually lot of photos and illustrations, proper methodology of examination. And also subscribe my YouTube channel, SRB Surgical Insight, which is free. You can learn surgery on day-to-day basis. Daily MCQs are coming, weekly lectures are coming, live sessions once in 3 weeks where student will present 1.5 hour discussion with the senior faculties. You can interact and have a certificate if you join the session. So please subscribe my YouTube channel. And also have DigiNow lectures for 1 year. 220-hour lectures are there. Entire surgery is covered with the examination, clinical part, operative surgery, specimens, instruments, specialties, general surgery, everything is covered. It will help to learn surgery with my manual book, clinical book, with my YouTube channel. You can learn surgery entirely properly to make your learning easier and faster and understandable. And through my YouTube channel, you can learn surgery day-to-day basis with interest, actually, with a lot of interest and understanding. And so that daily you can learn surgery easily. So again, I request to subscribe my YouTube channel. So students, I hope you have understood this clinical approach to thyroid swelling very well. Thank you so much.